Thank you for inviting me here today. Okay, so as Sarah said, I'm Renée Hoenderkamp. I'm a GP in North London. I also do some private GP, but not much, I'm afraid, anymore, because there's too many other things that have taken over. I was on the NICE Thyroid Committee. I'm the resident GP for BBC Radio London, where we take calls twice a month in a show, and those calls are often about thyroid disease. I'm a Pulse blogger, and some of you I know because you've already spoken to me about it, have seen some of the articles I've done in there about thyroid disease and particularly T3. And as Sarah said, I lost my thyroid to the surgeons about 16 years ago, although I think I'm a bit older now, so it was probably a bit more than that. 20. Oh dear. Okay, so today I'm going to do a very quick what is the thyroid, how does it work, but I'm aware that much of that has gone on this morning, so I really will do a whistle-stop tour there. What sort of symptoms and signs we see of thyroid disease in GP, and I will be coming at this from a GP perspective because that's what I do day to day. What tests we do, what tests I do when I'm in GP, and those are not necessarily always the same thing, how we interpret the results, how we diagnose hypothyroidism or subclinical hypothyroidism, then what we do to treat it, manage it, test it, and common patient concerns. And I know lots of you sent in some questions, so I picked some of those off that I hear all of the time. And those questions are here. I'm not going to read them out because hopefully I'm going to answer many of them as we go, and then if not, we'll have a panel later. And I know some of them were answered in the panel earlier because I arrived just about then to hear those. So the first question is, as a GP, who are we seeing for thyroid disease? Who's walking in the door and may have a thyroid condition? Well, it's a complete mix. So sometimes it's patients coming to me specifically saying, I'm worried about my thyroid. And quite often the worries there are fatigue and weight gain or weight loss, but mainly weight gain. Then there might be patients who have lots of other symptoms, and as a GP, as I'm assessing and trying to work out what's wrong with them, I'm thinking, is this thyroid disease? Do we need to work out what's going on here? And then, of course, there are those patients who have existing hypothyroidism and they're being treated, and it's about their management or when things start to go wrong. And these things do happen. Just because you've got hypothyroidism, you've been treated, your blood tests are in range, doesn't mean that next week, next month, next year, things don't change. And they certainly do, and I know that personally, of course. So a very quick scoot through the thyroid. Obviously, the thyroid with the pituitary gland and the hypothalamus is a negative feedback system. So the more thyroxine you've got in your body, the less you need, or that's what your brain thinks. And that level of thyroid feeds back to your pituitary gland and says, we don't need as much thyroxine, please tell the thyroid to slow it down a bit. And then your TSH, which is the hormone that comes from the pituitary gland, will go down so that your thyroid is less stimulated and you'll produce less. And conversely, when you're needing more because you're becoming hypothyroid, that will feed back to your pituitary gland that you haven't got enough thyroid hormone circulating, and it will then pump out more TSH to tell your thyroid to produce more hormone. So, in very simple terms, the higher your TSH is, the more thyroid your pituitary gland is, more thyroid hormone your pituitary gland is asking your thyroid to produce, and the lower it is, the less. And that always seems a bit paradoxical because you think when it's low, it's bad. So how do patients present? Well, lots of them feel like this, like poo, basically. They come in and they feel absolutely rubbish. And it might just be a single symptom. It might just be fatigue, but it might be fatigue that's so debilitating that they can't think, or they can't think, you know, mental fog, that kind of thing. And that's the kind of thing that we see in GP. The symptoms are vast. I couldn't list them here because I'd need so many slides, and that's one of the reasons we didn't really list them in NICE, because there were so many. How did we differentiate between which symptoms were really, really common, which were absolutely connected to thyroid, because there's a massive crossover too. And as a GP, I have a specialism in menopause as well. And so the crossover between thyroid symptoms and menopause symptoms is absolutely massive. and very difficult sometimes to unpick because, of course, as we get older, our thyroid sometimes starts to slow down, and so does our estrogen levels because our ovaries are packing up. It's lovely being a woman, by the way, sorry to the men in the room. So there's that to consider as well as a GP. You know, what am I actually dealing with here? But just to name just a few, as I said, weight gain, constipation, you know, dry skin, thinning hair, feeling cold, sleeping all the time, not eating at all, putting on weight, and so it goes on. So what does NICE say about testing? And I think it's really important as a GP that you know that what NICE says about testing and what GPs actually do are not necessarily the same thing. And so answering one of your questions earlier is about how do we get GPs, you know, on the same page as the NICE guidelines. It's really, really hard. And it's really hard with lots of things. It's really hard with menopause. Women are treated appallingly for menopause. We've seen programs about it, and I've done one of them. And they're driven to private doctors, and the same is true of thyroid quite often. Quite often it's not the GP, by the way, it's the CCG. So I asked for a TRAB last week for somebody who was very, very hypothyroid, and it was refused. I was told by the lab I couldn't order it. So it's not always the GP. The GP might be asking for the right test, but the CCG, the labs have decided not to do it. But that doesn't mean you can't point out the NICE guidance to them, because if it's in the NICE guidance and you're worried that your GP or your CCG is refusing a test, then you are well within your rights as a patient to take that guidance to the CCG and say, can you explain why you're not doing this, please? Because this is what should be happening. So, NICE says consider tests for thyroid dysfunction if there is a clinical suspicion of thyroid disease, but bearing in mind that one symptom may not be indicative of thyroid disease, which is fair enough. As I said, there's a lot of crossover with lots of different things. Offer tests for thyroid dysfunction if somebody has type 1 diabetes, and that's really important because if you've got a tendency to an autoimmune condition, then you may well develop others along the way. If somebody has new onset atrial fibrillation, they need a thyroid function test. That's absolutely clear. The next one I, as a GP, always struggle with, because consider tests for thyroid dysfunction in patients with depression or unexplained anxiety. Well, firstly, I think anxiety is often unexplained. You know, people often feel really, really happy and comfortable in life, but are having massive panic attacks. So there is no rhyme or reason for why people get anxiety. 25% of my workload as a GP is people with depression and anxiety. So I would be doing an awful lot of thyroid function tests if I tested all of them, but certainly for some of them. And I think I was telling a story earlier to somebody that I have a patient who's a psychotherapist who told me last week that she's recently seen 2 patients sectioned. One of them actually had undiagnosed hyperthyroidism and one of them had undiagnosed hypothyroidism. And certainly when I was early in my journey with my thyroid hormone balancing, my partner used to ask me to please take some more thyroxine. So there's certainly some sort of correlation with mood. So what do NICE say that we should do as initial tests at GP? Well, they tell us to consider measuring TSH, which of course we would always do, and that goes without even thinking. Alone, when secondary thyroid dysfunction, so pituitary disease, is not suspected. So when we think this is a thyroid condition, we should test TSH. Then if the TSH is above the reference range, to measure T4, and if it's below the reference range, to measure T4 and T3. We talked about cascading on the NICE committee until we were blue in the face. And I will come on to that in a minute, but that's kind of what the lab should be doing. If they do a TSH for you and one of those is out of range, it should automatically trigger the next test. That doesn't always happen either at GP level. And depending where your GP is, again, CCG to CCG, will depend whether or not they can order tests. So I can order a T3 now. I couldn't in my last job in a different CCG, literally 2 miles down the road. So it really does vary CCG to CCG. So again, use the NICE guidelines and ask for the tests. Considering measuring TSH and T4 for adults when secondary pituitary disease is suspected. If the TSH is below the reference range, measure free T3 in the same sample. and consider repeating the test for thyroid dysfunction if the symptoms get worse, if new symptoms develop, if things change. And I think that's really important. I don't think we should be seeing patients and just assuming it's okay. I personally, as a GP, don't think we should be doing medication reviews on thyroxine without the patient there, but it does happen. We go through because of the way that GP is structured and quaff and targets, and we look at what's going on and we say, yes, the patient's fine. I think it's always good to see the patient and just make sure they are fine. As I mentioned, cascading. So this is where you do one test and it triggers another. And I know David is a great fan of this. And you're still here, you are. And we did talk about this at great length. I think it's great if it works and if labs do it. And they don't all do it, unfortunately. So what does all of this mean? You've had your test, you've been to the GP, you've had your tests, and you get your results back. Well, as I said, hypothyroidism is when your TSH is above the reference range and your free T4 excuse me, is below the reference range. And subclinical hypothyroidism is when your TSH is raised, but your T4 is within range. So those are the two diagnoses that we're looking at today. So you're now a happy poo because you've got a diagnosis because you've had your tests done. But there's still a long way to go, isn't there? So what now? So you've got this diagnosis of hypothyroidism with a low T4 and a high TSH. So your GP should be considering what other tests are needed, like TRAB, thyroid antibodies, treating you, and planning and managing your ongoing journey, because it doesn't just end there, and it really doesn't. And I remember I went to medical school later than some, and I'd already lost my thyroid. And I remember the endocrinologist who gave us the lecture about thyroid function saying, oh, you know, sometimes we have to take out the thyroid, and then it's really easy, you just give them T4. And you know, I think for most people, many people, it is easy, but there still is a significant cohort of people for whom it is not easy. And it isn't just as simple as giving T4, and it can take a long time to find the balance that you need. So antibodies, NICE says, consider measuring thyroid peroxidase antibodies, TPOABs, when TSH levels are above the reference range, but do not repeat this. Why would you want the antibodies? I mean, essentially, you want to try and find out what's going on. You know, what are you dealing with? Are you dealing with a Hashimoto's or a thyroiditis or a Graves' disease? And that's what the antibodies do. So I don't know why the lab said no to me, but they do. They do sometimes say no, sadly. And then treatment. So once we've got this diagnosis, why do we treat you? Why don't we just leave people hypothyroid? Well, it's better than for your heart, as we've already heard, to be slightly hypothyroid. But if you're long-term hypothyroid without treatment, you will slowly develop over time a low, hoarse voice, a very puffy face, thinned or partly missing eyebrows, tends to be at the edges, a very slow heart rate, anemia, hearing loss. You'll feel like a poo. We've already seen that. And ultimately, if you didn't have any functioning thyroid, or you'd had a thyroidectomy and you didn't treat it, you would die. And let's not be like Tom. So talking of that puffy face and the dry skin, this is me. This is me 20 years ago, 16 years ago, I keep saying 20. 3 weeks without any thyroid hormone at all. And bear in mind I was younger, I had fewer wrinkles for sure. And you can see by my eyes how puffy they are. My whole face, I've got a double chin. And believe me, I've been built like this since I was at school. And I felt as rubbish as I looked. And that just brought home to me how important the thyroid is. It really is. It runs everything, and we don't know really what it's doing until we don't have one or it goes wrong. I've always said I'm going to write a book one day that says look after your thyroid because you'll miss it when it's gone. And that's how I felt back then. So let's talk about treatment, because most of this can be done at GP. It's very rare that we need to refer somebody with hypothyroidism to secondary care, because mostly it works and we can do it at GP. So the NICE guidance says that the dosage for an adult who's well and under 65 is 1.6 micrograms per kilo of body weight per day. And that's a guide, obviously, as all of this is. But it's quite refreshing to have that dose because it used to be a range. And you used to have GPs picking the lower range and then watching people suffer on while they slowly increased it. But now we can go in with this dose, and in the main, that dose will work for people. But again, you need to look at the patient, and if it's not working, tweak it. And if you're dealing with older people or people with underlying conditions, especially heart conditions, you do start at a lower dose then. So 25 to 50 micrograms per day, and then slowly titrate up, because thyroid hormones can be an irritant to the heart because they're being converted at the tissues to T3, which is the active hormone. And certainly you need to think about it in somebody who may react more strongly than somebody who is healthy and can just have a normal dose. So what about other treatments? So NICE specifically says do not routinely, the word routinely is there obviously, offer liothyronine, either alone or in combination with levothyroxine. And this again varies GP to GP and CCG to CCG. And there are CCGs that have red listed this drug, I would imagine most of them now, but there are still CCGs that haven't. My CCG in North London hasn't. We can use T3 without a problem, we can prescribe it, we don't get in trouble. And again, it's not right, but CCGs are looking at money. So CCGs are red listed in this drug purely on money. It's not to do with the NICE guidance because this happened long before these new guidelines came out. The price of T3 went up dramatically and CCG started to red list it. GPs don't have to, this is another piece of information, don't have to follow a red listed drug. Your GMC commitments say that if you think something's in the best interest of a patient, you should prescribe it if it's on the formulary, but most will, because they think they're going to get in trouble. Their medicines management team will come and speak to them if they prescribe red listed drugs too much. It also says do not offer natural thyroid extract. I know there are some CCGs, and I think it was Mary who said this to me on the committee, who do prescribe NDT. I've not seen it, and it's not something that I would feel comfortable prescribing because I just don't know enough about it. But these guidance rules have been put together from the evidence and uncertain long-term effects. And certainly the one thing we saw on the committee, that there isn't the evidence to support the use of T3 and alongside T4. Most of the trials that met the criteria for NICE just didn't show any benefit. And this was, lifestyle questionnaires for patients to ask them if they felt better after a trial on T3, and mainly they didn't. There are certainly patients who do. I'm one of them. So, you came in as a poo, you've been treated, and you now feel like your old self. And certainly, for me, well treated, and I'm treated and stable now, I feel back to my old self. And, hopefully that's where we can get most patients. But I appreciate there are lots of patients who never feel well. So, I've had a joke about feeling like a poo and ending up your old self. But seriously, NICE say that we should maintain the TSH within the reference range, which of course all GPs will be aiming to do. I think the next point is really, really important, and I felt very strongly about this on the committee, that if symptoms of hypothyroidism are carrying on, even when the TSH is within the reference range, then we can add more thyroxine to see if you feel better. And I think I'll be corrected if I'm wrong here, that people feel better generally if TSH is under 2.5. Isn't that what some of the research says?
Younger people, maybe.
Okay.
I don't think the evidence
is strong.
Really supports it.
Okay. But I certainly think if you're sitting there with a TSH in the upper range of normal, but you're still feeling unwell, you should be able to sit in front of your GP and say, look, I know that the computer says I'm fine, but I'm not fine, and I would like a trial of a little bit more. And obviously, looking at side effects, checking your heart rate, things like that. But it is in the NICE guidance, so we should be able to do that, and your GP should be able to do that. And maybe GPs don't know that. And how they get to know that is really, really tricky. We have to train ourselves. And a lot of people don't know this. Once we have qualified as GPs, and that's a 3-year training course, we go out into the big wide world, and what we do thereafter is entirely down to us. There are no further training courses that are given. We have to pay for anything we go on, and we have to update ourselves if we want to go on courses. And the list of things that we could update ourselves on is vast. So I am defending GPs here because it's vast. There is only so much time in a day. You know, do we go to the one on kidney disease, menopause, you know, thyroid disease, leukemias? It really is vast. So that's why GPs aren't always up to date, and I'm not defending them not being up to date. I'm trying to just put some context behind that. So somehow, I think with the, you know, days like this, where we can educate you, and you can take the nice guidance forward through some of the support groups and charities where they can bombard GPs so that they look at the nice guidance. I try quite hard with my vlogs and with my tweets and all sorts of things that I do. And it's just a constant, you know, trying to get to GPs and get them to read the new guidance. And that stands for every subject. So it's hard, and that will probably explain to you why GPs are not always up to date. So coming back to this, TSH can take up to 6 months to return to the reference range for people that have been really, really hypothyroid. So when your TSH has been sky high, your thyroid hormones may be fine for you and you may be feeling fine, but your TSH may take a long time to get back into range. And similarly, when it's been very suppressed for a long time, it can actually take quite a long time to come back up. So it's important then to look at T4 alongside of TSH to see what that's doing, and to then look at the patient and see how they're feeling. So when do we test? Every 3 months until stabilised, and we're calling being stabilised 2 measurements that are about the same, 3 months apart, and then once we get to that point, once a year, unless something changes, obviously, and if something changes, then we'll test again. There's no limit on how many tests a GP can do. You know, they can order you a thyroid test whenever they want to order one. A lab might come back and say to them, this was only done a month ago, but then it's up to them to either justify that with the lab or wait. Consider measuring T4 and TSH for adults who continue to have symptoms of hypothyroidism after starting levothyroxine. Now, obviously, this is assuming that the TSH was in range, because otherwise it would have triggered T4 anyway. So subclinical hypothyroidism. This is when your TSH is out of range, but your T4 is normal. And we do see this an awful lot. And some people actually sit with subclinical hypothyroidism for years, never get treated because they feel fine and their T4 is in range. And that's a really common GP patient. But they may just fall off the cliff at any point. So it is important to test regularly. So what do we do with it? So if your TSH is under 10, and your T4 is normal, and you don't have symptoms of thyroid disease, then we just monitor, because it's probably just going to stay like that. We do 2 separate tests 3 months apart and have a look at what's going on. If, however, it's over 10, or it's under 10 and you have symptoms, then we would consider treating, and we would consider a 6-month trial of levothyroxine for those who, as I've just said, have TSH above the reference range with symptoms under 10, or that their TSH is over 10. If there's no symptom improvement at all, you re-measure the TSH, and if the level is raised, we can adjust the dose and see if we're just not given that patient enough thyroxine. But if it persists, if symptoms persist whilst the TSH is within range, we would consider stopping the thyroxine and then going through what the NICE guidance says is the way to monitor untreated subclinical hypothyroidism. And I always think it sounds really weird to say untreated subclinical hypothyroidism, because it sounds like you're just actively not treating something that needs treating. But that's not always the case with subclinical hypothyroidism. So for adults with untreated, so we've been through the trials, or they haven't quite gone over the threshold for treatment, or they've stopped levothyroxine because it wasn't making any difference to their symptoms, we would measure TSH and T4 once a year if they've got symptoms of, if they've got features suggesting an underlying thyroid disease, such as thyroid surgery or raised thyroid autoantibodies. Because some people have raised thyroid autoantibodies all of the time, but do not have thyroid disease. And so they sometimes fall into this category as well, where their TSH is a little bit raised, but their T4 is okay. And then we do it once every 2 to 3 years if they've got no features suggesting underlying thyroid disease and they remain well, or they've had a trial of levothyroxine and it hasn't changed things. So how does a good GP approach it? So this is obviously just my view, and other GPs will have different views. But my view is very much that they must see the patient in front of them. So A, they must have the patient in front of them, and B, they must see the patient in front of them, not the screen. You know, they shouldn't be talking to the screen. They shouldn't be treating the TSH. They should be treating the patient. So thinking to themselves, could it be something else? Because there is this real crossover with other diseases. It isn't always thyroid, even when we think it probably is. Could it be something else? Have I excluded absolutely everything else that this could be, that could be causing these symptoms? What's going on in the patient's life? What is changing? Because sometimes big stressors in life can cause thyroid to go askew. And, you know, whether that's a cortisol effect, you know, because there's too much stress and it will normalise. But it's always, I think, important to know what's going on in your patient's life. Is there so much going on in your patient's life that they have reason to be anxious or depressed, and actually it's probably not their thyroid? So it really is getting to know the patient in front of you, seeing the patient in front of you and thinking about it. Really important to involve the patient in your plan, because if they're not on board with what you're doing, you know, it's not going to work and it's not going to end well. You know, have a discussion about it, include the patient's thoughts about it, or try and include them. Obviously, if they're asking for things that we can't give, then we can't give it, but try. Recognise the nice guidance as that it is guidance, and it's a really useful tool, especially for GPs who are not up to date. And so as patients, I would encourage you to take it forward, the bits that are relevant to you. Ask the lab for tests that you want. So, you know, if a lab turns down a test and says no, as a GP, I would pick up the phone. If I thought it was really important in what I was thinking and what I wanted to do for that patient, I would pick up the phone and have a debate with the doctor in the lab. And there will be a doctor in the lab who can talk to you about it. You know, and sometimes they'll say, no, we'll cascade it if, boom. But sometimes they'll say, okay, I hear what you're saying, we'll do it for you. So I think that's worthwhile as well. So if your GP says no because their lab won't do it, ask your GP to speak to the lab for you if it's that important. And always, I've thrown this in, even though the guidelines didn't mention pregnancy, we didn't cover pregnancy at all, but a good GP should always be on alert for a hypothyroid patient planning pregnancy or presenting as pregnant, because it's really, really important for that new baby that their thyroid disease is well treated, and they probably need to increase their dose quickly before they then get to the high-risk pregnancy clinic, which is where they would go with thyroid disease. So, going back to those questions that I put up at the start, you know, firstly, why is my GP happy with my normal blood test results? I think I may have answered that for you in everything I've said, and I think sometimes it's just about not looking at the patient. Sometimes it's just looking at the computer and the TSH, and that's why I think it's really important to look at the patient, because if you're looking at the TSH and it's in the upper end of normal, but your patient still has these kind of symptoms, then you probably need to treat them a little bit more, or at least try. I've answered the second one. What training is in place? None. No training. Once you're out of medical school and then your GP specialist training, there's none in place. Every GP will have things that are offered to them by their CCGs, again very variable, but they still have to access them, they have to give up their own time, and quite often they have to give up their own money. Why is there such a long wait before patients can get to a consultant? Well, I think it's the same on everything now. I mean, there isn't a speciality that I'm referring people to that isn't absolutely heaving, I'm afraid. I don't think it's unique to endocrinology. And I think I heard you answer earlier, why is my whole system broken down? Because your thyroid is your engine, and when it goes wrong, everything breaks down. So I don't know if you want me to take questions now or later. Okay, so I'm going to take questions later, everybody, but I hope that was helpful.